Hi, everyone. This is Pam Brandon with AGE-u-cate Training Institute. I hope everyone is doing well, and we're going to give it a few minutes while everyone pops on to the webinar. And so we'll just wait just a minute to get everyone settled in. And thank you for joining. All right, continue to have that participant number grow. So a couple more minutes and then we'll dive in. Okay, it is a minute after. I see the participants, a few still coming in, so let's go ahead and get started. Welcome, everyone. I'm Pam Brandon with AGE-u-cate Training Institute, and thrilled to have you here. This is going to be a great educational discussion for everyone, certainly for me. A little bit about AGE-u-cate, if you are not familiar with us. AGE-u-cate is a training institute. We help caregivers see the person, not just the diagnosis. Through immersive education, we transform how care teams understand and support those living with dementia, fostering dignity, compassion, and meaningful connection at every touch point. And I'll talk a little bit more about how we connected and why with this great team from CHAP. So welcome, Vicki Barron and Jennifer Kennedy. We are thrilled to have you here and to join us in this discussion about the hospice tool, which is a fairly new tool in the space, and lots to learn on this tool and how it is going to affect in hopefully good ways, the hospice and home healthcare space. So first, I'd like to introduce Vicki Barron. Vicki is a registered nurse with more than 40 years of nursing and healthcare experience, including roles with home health, hospice, home care, and home infusion providers. Vicki has served as CHAP's site visitor, clinical consultant, and provided education and support to home health and hospice providers nationally. She's also served as an administrator, clinical director, direct care registered nurse, and QAPI team member. At CHAP, she directs and engages in the planning, development, and implementation and evaluation of education programs and activities, including CHAP's American Nurses Credentialing Center and Accredited Provider Program. Did I get that all right, Vicki?
Yeah, kind of a tongue twister.
It's a lot. And then our other guest is Jennifer Kennedy. She is Vice President for Quality Standards and Compliance at CHAP and is a nationally recognized hospice expert. I'll get it out. She has extensive experience as a leader and nurse in diverse healthcare settings and has worked in hospice and palliative care for the last 35 years. She is a certified healthcare compliance professional and has a doctoral degree in healthcare education and policy. She is the lead for the CHAP quality and compliance team and interacts with CMS, their contractors, and individual states related to regulatory and quality matters for home-based care. She was honored for the UK's St. Christopher Hospice as a nursing pioneer for their 2020 palliative care nursing project and is a board of directors member for the Hospice and Palliative Care Network of Maryland. She speaks at national and state events, is a published author, develops specialty education, and teaches graduate healthcare administration courses at the university level. I just don't think either of you two ladies are busy enough. And for those of you who are not familiar with CHAP, I found this very interesting about your history. CHAP stands for the Community Health Accreditation Partner, which is an independent nonprofit accrediting body for home and community-based healthcare organizations, and was the first accrediting body in home healthcare. They began as a joint venture with the American Public Health Association and the National League for Nursing in 1965. I'd say you go back a little bit further than AGE-u-cate, who was just 13 years old. So no wonder you know more than I do about this topic. And CHAP is a CMS approved accreditor. So obviously lots of experience here, and just very excited to dig in with these ladies on the Hope tool, and understanding what the Hope tool really is. This started and was implemented in October 1st of 2025, so very new tool out there for the market. And when I connected with Vicky, I had just so many questions about this and said, there's so much that has been out there on the regulatory side, which is, extremely important. But let's dig in a little bit further with more the speaking about the pharmacological and non-pharmacological, all of those tools that now can be implemented with the Hope tool, right? To make it more robust and to help providers. And I know, Vicki, you said you're very positive about the Hope tool and what it might bring for quality of care in the hospice and home care environment. So we'll be talking about that, and we'll be talking about the age-friendly care at home using the 4 M's, which also is an area that is not talked about enough, I think. So from here, I'm going to let the two of you start talking, because I know you can talk a lot about this subject. So Vicki, I'll
So
let you go ahead.
I'll get started. Thank you so much, number one, for having us. Interestingly, when Pam reached out about this, it was kind of that aha moment of, you know what, the Hope tool is specifically for hospice providers. So if you're in another discipline or another service line, if you're in home health or if you're in a SNF or a hospital, you're not required to complete the Hope. And I always like to clarify that. This is not something that is going to be taken over and all of a sudden you're going to have to do. But following the concept of it could be really, really helpful in developing your own plans of care when you're providing care for patients, and then also working with hospice providers too. So it's kind of an interesting approach, and I really like the thought of it. When Jennifer and I were talking about it, she's presented a lot of information on Hope over the last year. Now we're almost on a year and a half, which is really crazy to
Mhm.
think. Even though it just went into effect in October of 2025, everybody was ramping up. And so there was lots of conversation about it. But definitely, we've learned a lot as, people that are out here trying to educate. And we've learned a lot from providers that have started using it. So we really wanted this today to be more of an open conversation of just us sharing some insights, kind of some suggestions. This is not regulatory. If you're not in the hospice world, again, you don't have to complete the Hope assessment, but maybe you can take some of this information home and use it in whatever practice you're in. So I'm gonna pause there for a second and see if Jennifer wants to add anything, kind of piggybacking on that, or we'll just keep on moving forward.
Yeah, absolutely. Thanks, Vicki. The Hope Tool is an exciting, dynamic, new introduction into hospice practice. And if we think back, we as hospice providers have been collecting data with the hospice item set for years. And that was always meant to be a placeholder, essentially, until a standardized tool could be developed. I, I hate to say kind of like the Oasis E or kind of like the MDS and the nursing facility, but the concept of the standardized tool is the same. when you put it up against Hope. And what it's meant to do is to collect the same information from all providers who are taking care of individuals at the end of life so that they could see what that looks like and build on that as the tool will mature. And it will mature for sure, based on the data that CMS will collect in the early years of implementation. And I think it's really fair to say here that CMS's intent for implementing the HOPE tool is twofold. One, obviously, is to collect data to inform future quality measures. And they're really aiming to get patient level quality measures rather than just process measures that come out of this standardized tool. So I'm excited to see that. That would be a first, and it's really, really hard to develop patient level measures in the hospice space. So that's the first thing. Unfortunately, the second thing is that the data that CMS will collect or is collecting is going to help them inform a future payment methodology for hospice providers as well. So when I'm out and about, I always say, your per diem payment, love it, hold it, cherish it, because you're not always going to have it. It is going to change somewhere down the line, because what we have now as a per diem payment methodology is really not going to be sustainable into the future. So a lot of exciting things, maybe not the payment methodology, but a lot of exciting things I think are poised to come out of the HOPE assessment tool.
Mhm. Mhm. And just to clarify, if someone is not in the hospice space, the per diem payment model is you're paid every day a person is on service. And so it's not based on the number of visits that you provide or which discipline provided. You're literally paid a flat fee for every day that they're on service. And so, yes, we do anticipate at some point that that will change. But yeah.
And while CMS took the items that were in the hospice item set, or the HIS, and embedded them into the HOPE tool, they also expanded some things, which I was very happy to see. Expanding some of their demographic information that they're collecting, like language information or cultural background information, and really expecting the administrator of that tool to be a little more respectful, to be a little more intuitive about how they're asking about a cultural background or a racial background, and things of that sort. So I think that's really important when we talk about the bigger health equity and quality piece, that is not just static to hospice, it's static to everything, all types of providers, right? And then really stretching out some of that clinical data collection with, yes, we're going to take the deep dive into a pain assessment or a non-pain assessment data collection, but what's the impact? And I know, Vicki, we're going to probably talk about that in just a little bit, but what's the impact of that pain? It's really, I think, forcing, again, facilitators and hospice interdisciplinary teams to do a little more critical thinking. Not that they weren't doing it before, but now they're documenting and they're on the hook for it, right? So now you're accountable for it. So I think accountability does tend to push a little more of the critical thinking that has to happen.
Yeah, I totally agree with that. I'll shift gears a little bit on that and talk about, because she's talking about how we've got to be accountable. So the HOPE tool holds people accountable, particularly in the first 30 days of the hospice admission. So within that first 30 days, there are HOPE requirements. The only thing that might fall outside of that 30 days is the discharge, and that's whenever they discharge. And so that could be, 6 months from now, however long that they're on service. But those first 30 days, there really dictates on what we're going to do and how we're going to see our patients. And it was interesting when it first started, I would go to conferences and speak to groups, and they would say, we're going to have to hire new nurses. And I'm thinking, okay, I don't understand. That was a little concerning. I'm like, well, if you have a patient and something changes or they have a need that you identify on a visit, are we not going back and seeing them? And some providers, I'm not sure if they were. A lot of them were like, this is what we kind of already do anyway. They're just capturing it. So definitely that was interesting, just, as someone who was providing information and education about it, to get that feedback. But again, most providers were like, no, this is kind of what we're doing already, but CMS can capture that information. And, like Jennifer says, this is all linked back to driving that quality. We want quality improvement. We want to respond to our patients' needs. When we think about quality improvement, we also think, well, you know what? If our quality is better, probably going to have better patient satisfaction. So, super important when you start pulling all those pieces together and how it really can drive what we're doing to meet the patient's needs.
Absolutely. And I've gotten many questions about why are they only interested in 30 days? Why? Why is it only 30 days? And I have a couple of ideas about that. Um, Firstly, we have a two-tier payment system in hospice. So for the first 60 days that a patient is on service, a hospice provider is paid a little bit more because CMS in their research felt like the care that is provided is more intense in the first 30 to 60 days of service. Okay. And then once the patient reaches 61 days and beyond, the payment rate is dropped to a lower payment rate. And then they would be seen as going into a longer length of stay, where maybe the intensity of the care is not so great as it was in the beginning. The second thing is, I just actually saw that the data from the MedPAC report that came out just about a week ago cited that 52% of Medicare beneficiaries in 2024 actually accessed hospice care. That's really great. A quarter of them were in the very short stay window, right? Meaning that they were in the 10 days or less, 5 days or less, 3 days or less. So um, when you sort of put some of the pieces of the puzzle together, you can see maybe where the 30 days is coming from and why CMS didn't design something in terms of collecting data beyond that.
And that actually makes a lot of sense. And for those of you that are on this call, you know that when you get those patients and they come on their high acuity, they are sometimes imminent. And we have to run in. We're almost like the firefighters, the rescue. Everybody just has to dive in to try to meet the needs of them, and then they're gone. And for those of us that understand that hospice philosophy, it's like, wow, they didn't really get the benefit of it. I mean, we
Right.
met their needs how we could, but they didn't get the whole experience. And that's not only for the patients, it's for their families as well, for their caregivers. So certainly that intensity can be, really, really a challenge. It's a strain on our staffing. If we've got a patient that comes on and they need everybody, all hands on deck really quickly, and then they're gone in 24 hours, we still have to do all the documentation. We're still having to pull all those pieces together, have the orders, have the plan of care signed and everything else. And it can be a drain on the resources. And so, this to me hopefully will indicate, and every time I say the word hope or hopefully with the hope tool, I'm like, maybe that's why they came up with that acronym. And the acronym itself, in case I don't think I mentioned it, but it's hospice outcomes and patient evaluation. And so it's a very fitting acronym, but I do think for me, it gives me a lot of hope. Here I go. But in that we as hospice providers providers can certainly, drive that plan of care, meet the patient's needs, hopefully get them on service, at a time early enough to be able to really allow them to have the full hospice experience.
Yeah, I can't agree more. I also am really looking forward to seeing what the first batch of data looks like. And I think as hospice providers use this tool, they'll become more proficient, right? And we should see better data, cleaner data as time moves on. But I think it's fair to say that in order for CMS to meet their goal of developing additional measures from the data and looking at how they're going to pay hospice providers differently down the line, there are going to be changes to this tool, meaning that maybe some data elements will stay, maybe they'll be swapped with other data elements. And I always say hospice, I always look at hospice as the caboose on the Medicare train, right? Um, Everything has come to hospice after it's been tried or implemented in another provider type in CMS. So all we have to do is really look to other provider types, particularly home health, to see how things have been implemented, and that can give us an idea of what we might be able to expect down the line for the hospice provider type.
Yep, I totally agree. So let's shift gears just a little bit and we'll talk through what those 30-day expectations are. So when a patient is admitted to hospice, the assessments that are associated to HOPE are considered HOPE assessments. So you have a HOPE admission assessment, and then we have 2 opportunities to do HOPE update visits. The HOPE admission assessment occurs days 0 through 5 of the hospice admission, and day 0 is the day of the admission. So it's 0, and then we add 5 more days. We should gather all the information to complete that HOPE admission. Now, during that admission, and I love to use this as an example because honestly, when I was a nurse, a direct care nurse, this was the scenario that popped up a lot. We would admit a patient to hospice. Maybe we identified that they were having pain or they were having some symptom that was not well controlled. And so we would call the hospice physician. Of course, we would get the certification of terminal illness, that verbal certification from them. And then we would say, these are the things that we assessed, and they would order maybe a new medication. So, medications don't show up. We can't just pull them out of a bag. They have to either be picked up from the pharmacy or delivered. And often later that day, it would be delivered, or maybe the next morning it would be delivered. And then we would go back. We might do the education with the family, with the patient, start the medication, and then instruct them on how to use it. And in the world of HOPE, and so when we think about HOPE, that would be considered a symptom follow-up visit. We identified a symptom, and first, we identified a symptom that was moderate to severe impact. So it was impacting them moderately to severely. We got the order for it, and we went and did a follow-up visit. Now, I'm going to pause right there and say one question that I've had from folks is, well, what if it's not moderate or severe, but we still want to go back and see them? There is nothing that says you cannot see a patient as frequently as you feel as hospice providers you need to see them. So, think what you've done in the past, be intuitive in your care, but for the sake of HOPE, if that symptom impact was moderate or severe, within 2 days, it gives you a 2-day grace period, you are required to go back in and perform a symptom follow-up visit. And so it actually makes a lot of sense to me. And we're just capturing that data, that this is what we identified. We went back in to see the patient. Hopefully we get resolution. We get that resolution. Now, let's just use another example of we go back in and the person's pain that was moderate to severely impacting them is well managed now, but all of a sudden they've developed, severe nausea and they are unable to eat and they're having a lot of problems. Another question that pops up is, well, do we still need to do another symptom follow-up visit? I always say, for the sake of HOPE, there's not a second symptom follow-up visit associated with one assessment. but that's no reason not to go back in and see them. So just keep it in mind. The care we provide, we absolutely want to meet the regulations, but our main priority as providers is to meet the needs of our patients. Meet them where they are, do what we feel is in the best interest of the patient.
That was well described. And I have to tell you, in the beginning, when we were sort of rolling out education, it kind of frightened me
Me
when I
too.
heard things like we're going to need extra staff. And weren't you already going to do a follow-up visit if someone had a severe pain description? Some of those things kind of frightened me, but I think sort of separating the wheat from the chaff, here's the documentation and here's the clinical care, right? Yes, you have to document, but you don't one the documentation should not constrain your care of that patient in any way. And
Exactly.
I'm an old hospice nurse. We didn't have HIS. We had soap notes. We
Yeah.
had when I was actually out in the field taking care of patients. And front loading, if it's okay with the patient and the family, front loading your visits at the beginning of care does a lot to establishing that relationship of trust, establishing the bond that you need to have in order to teach them about what's to come. And there could be, depending on imminence of death when they come on, you need more frequent eyes on that patient. So I, maybe I'm just too old, Vicky. I don't know, but I'm thinking, we should be really seeing patients more frequently in that
I agree.
beginning week of care. Um,
Yep.
and to review what you told them from that handbook, they're going to remember like 2% of
Yep.
what you reviewed in that handbook,
Yeah.
guaranteed. So, reinforcement and building the relationship and the trust and getting eyes on for assessment, all of that is really important at the beginning.
Yep. I mean, it is. It's that getting to know you phase. This is the
Yeah.
most. I always told clinicians and everybody on my teams, I would say there are no do-overs in hospice. We
Mhm.
cannot go in and drop the ball and, oh, well, next time we'll do a better job. This is such a pivotal time for the patient, for their families. We want to do it right. And so, like Jennifer said, we're not constrained by our documentation requirements. Provide the care that you need. Certainly, you want to meet the regulations, but really it is about meeting the patient's care needs. And do you have anything else to add on that?
I don't, and I'm of a like mind of what you think as well. And we know from the data out there that there are some providers that don't send a nurse but every 2 weeks,
Yeah,
and I don't, and that's just not quality hospice care, right? And I think the tool is helping to drive quality hospice care.
I agree. I agree. And so we talked about the HOPE admission, and that was days 0 through 5. Now we're getting to the HUV visits or HOPE update visits. And these are just subsequent visits. HUV1 is days 6 through 15, and HUV2 is days 16 through 30. And those, again, fall within that 30 days. So we've already said discharge happens whenever the patient discharges. But it can, for the sake of hope, those first 30 days, we should have completed all of those. Now, just like the symptom follow-up situation, the visits that we talked about within 2 days of the admission, we also are required to complete symptom follow-up visits for each hope update visit if that symptom impact is moderate or severe for any of the pain or non-pain symptoms. We'll shift into those in just a minute. But for those of you, again, that are on this call, if you're not hospice providers, I'm hoping that some folks are going, you know what, I get that. Like, we could use this in whatever service line you're providing, because to me, I like the process of it. I think it's one of the well planned out tools that's been created, and anybody can use them. I did notice that in the link, we've already put the CMS Hope link website in there, and that's where all of the materials are. Of course, you're not required to use those data sets outside hospice, but they can be useful tools, and they're out there for people to be able to see them. So definitely, hopefully, people will like them. But so, Jennifer, do you want to talk a little bit about symptom impact and
Yeah, it's really important to know that not every individual who goes in for hospice care or elects to have hospice care has pain. It
right?
happens to be a popular symptom, but not everyone has pain. Depending on what their diagnosis is and their comorbidities, they may have other non-pain symptoms, right? And I can remember, my mother was in hospice care for several years, and she'd never had pain. She took a Tylenol. That was it, uh, so we have to, we have to be very thoughtful when we talk about the symptom follow-up is what are we going back for? And if it is pain, that's very important. We need to get it under control. But if it's something like shortness of breath or constipation or nausea and vomiting, those are equally as important to
Mhm.
get under control. So I think that's my first thing I want to put out there is that um, I think pain is associated with hospice as one of the hallmarks of hospice care, but it's not always true for every patient. I also feel, and sitting on the board of a state hospice organization, I get to hear a lot of feedback from providers. And really, in the beginning, some providers were having difficulty about what is moderate? What is a moderate impact? What is a severe impact? What is a minimal impact? Sort of measuring that out to match with whether it's shortness of breath or whether it's pain, or, is it what might be moderate for me might be minimal for you, so trying to align everything up, I think was a challenge for some providers to figure out and um, get that situated within their organization so that their clinicians had an understanding of what moderate and severe or minimal mean as it relates to symptom follow-up. So I think listening, asking the right questions is really important. The Hope Manual gives you a few sparse suggestions as it relates to how a pain symptom or a non-pain symptom may impact. But I think we have to be a little more creative, out of the box, and critically thinking beyond just sleeping and eating and some of the things that were listed in the Hope Manual. And I'd love to hear your thoughts on that, Vicki.
I totally agree. I mean, it's interesting because your mother, you had an experience with her on hospice. She didn't have pain. When my mother was on hospice, she had severe nausea, no vomiting, but severe nausea. But none of the medications really worked for her. So we ended up not using pharmacologic medications. We ended up using, she liked quiet, she liked cool cloths on her head. You think about some music. I mean, there are things that
Right.
soothe people. It doesn't always have to be medication. And, that's something that we need to consider. And when you get a scale, when we think about pain scales and we're like, ask a person, on a scale of 0 to 10, how would you rate your pain? And they say, my pain is a 2. And you look at them and they're wincing and they're not able to get out of a chair. They're not able to tolerate a bath anymore. They're not eating anymore, but they're saying they're a 2. As clinicians, how are we going to rate their pain? To me, I would rate it moderate to severe in my nerve as a clinician. On the pain scale, they're saying they're a two, but I'm seeing that they're not able to function in almost any aspect of life, and there's not a lot of enjoyment. So, again, this is an opportunity for us not to just read scales, but to really use those critical thinking skills, our nursing judgment, and be able to make those determinations. And when in doubt, talk to your IDG. talk to your medical director. This is not something that
Absolutely.
just one person has to make that determination. I think the piece of hospice that I love the most is we have people to bounce things off of. We can talk to each other and say, this is what I'm seeing. What are your thoughts? And also coming up with, this method of pain relief or symptom relief is not working. What can we do outside of the box that might work for this particular person?
Yeah, and you bring a great example. The person who says there's a two, that's where we have to use our keen skill of observation and documenting what we're seeing, what we're observing, not being objective or rather subjective. We're needing to be objective, and that's that's when you have to go beyond the point and click of your documentation system, right?
Yeah,
Is all of that what you're observing, even though they say there are two, we have to capture all of that in order to figure out what plan of care we're going to pursue, obviously with their input, whether it's pharmacological or adding some non-pharmacological interventions into that plan of care. So that's a great nuance to bring to the table.
definitely, definitely. And we think about it, and we're not going to go down the medical review rabbit hole, but there are so many hospice providers that have been under medical review that they're starting to realize
Sure.
our documentation was not as good as we thought it was. I always tell clinicians, I always tell agencies, I can observe your care that you're providing, and you're doing a great job. And I can read this visit note, and it tells me nothing about the great job you're doing. So, we've got to prove ourselves. We need to toot our own horns, and we do it through documentation and
Yep.
using this as a kind of that prompt of, oh yeah, we did do a symptom follow-up visit. Oh yes, we did do this additional intervention. We did revise the care plan when we identified this issue. All of that shows that you're addressing the patient's needs, and it drives your quality improvement. I firmly believe that. So that's a little push for the improving that documentation piece.
Absolutely. And the symptom follow-up actually is in itself the data piece that is feeding a future publicly reported measure, or actually two measures. So again, because I've been in regulatory and compliance a long time, I immediately thought, how are some hospices going to do a workaround, right? They're going to say, yeah, don't document as severe or moderate, right? And then we don't have to send somebody back out. Maybe we can do intervention another way, or I don't know. I don't know what the workaround is because I don't think like that. But it hospices have to understand that the work that they're doing, i.e., their documentation, is going to influence how they look in 2028 when those two measures that are linked to symptom follow-up are publicly reported on Care Compare. So that could be a very interesting piece of information for lay people to look at when they're hospice shopping, right? Is the impact, how many hospices went out in 2 days. Obviously, a higher percentage would bode well for a hospice, meaning that they have good follow-up. Quality is a priority for them, et cetera, et cetera. On the opposite side, if you're not seeing a lot of that, it could uh, not bode well for that hospice in the public reporting realm. So you have to, even though we're just new to this tool and we're just getting our feet wet in it, we have to think ahead X amount of years because the data that will be actually it's in play right now and being collected is already feeding the outcomes of those two measures in the public realm.
Yep, yep. Definitely. I totally agree. And think about that. I mean, when people choose a hospice, it's nice that they'll have some information to go on. The more information they have,
Yes.
the better informed they will be. Certainly word of mouth is always good too. Sometimes people they don't know anybody they can talk to and say, what was your experience? Or did you have a good experience? So definitely it's really important. And it's our actions, and our actions are going to lead to a positive consequence if we do the right thing for our patients. So
Exactly. And I think that symptom outcome measure is really going to align nicely with some of the measures in the CAPS
me
tool.
too. Yep.
Yeah,
Yep.
very
Yep.
much so.
Yep. So we could probably talk about hope all day.
We could.
I know people have other things to do, but we do want to just touch a little bit on age friendly care. And I will tell you, I'm excited to be a part of CHAP, and this is one of the certifications that we offer, but age friendly care at home. And it aligns so beautifully with the Hope tool and with that whole, we want to drive quality, we want to meet the patient's needs, but it follows the 4M's framework. And if any of you haven't heard of the 4M's framework, the 4M's are what matters: medications, mentation, and mobility. And Jennifer, would you mind sharing a little more about it?
Yeah, I'm happy to. I was honored to come into CHAP when this project was new, and I actually was one of the people who wrote our standards. So Uh, and at first I couldn't like wrap my mind around it, but the more that I thought about it and the more that I saw the application of it, I said, this is brilliant because it's not another thing that clinicians have to do. It's just a framework to put your care that you're already doing into to ensure that it's person-centered and it's person-friendly, essentially. And it's really designed for older adults. And we know that older adults have some issues with medication overload, and there are certain medications that older adults should not take. We know that there are mentation issues. We know that there can be um, ambulation issues. All of those things are a confluence of what happens when you age out, right? And it's just a great framework to get all of that together. And it's a lens that a clinician can use to make sure that you're addressing each of those buckets. Every time that you go to see a patient. And the biggest thing is that those 4 amps are applied as a set, right? So I'm not just going to look at what matters to somebody. I'm going to look at what matters as it relates to their medication, their mobility, and their mentation, right? They all connect and they all hang together as an outcome for that patient. And I thought, particularly being a longtime hospice nurse, oh, well, we already do that. We know what matters to patients and families, but I don't think we do. I think we haven't gone a couple of steps beyond um, what what do you want to happen over the next, X amount of time, right? Oh, I want to be able to go to my granddaughter's wedding. I want to be able to last that long. Um, but there are other deeper nuances to that. If I if I'm a patient who's receiving hospice care and I want to see my granddaughter get married, but I also have a dog that I adore, right? And I want to be able to take my dog out into the yard and play with my dog once a day or watch my dog run around. So I need to be able to have the strength, the mobility. I need to be able to take medication that doesn't affect my mobility or my mentation in order to accomplish that goal. Right. And also make it to my granddaughter's wedding. I need to be able to ambulate there or have an aide to help me do that. I want to be present, so I don't want to be fuzzy from education. Um, so you see how it all connects and where I'm going. And I think every provider type, whether you're home health or hospice or wherever you sit in the healthcare continuum, age-friendly care is a great framework and tool to help you make sure you're giving the care that that patient wants and that is aligned with their needs and their wishes. Is that
Yeah.
enough?
No, I love that. To me, it makes so much sense. And like you say, we all thought we were doing it, but at the end of the day, sometimes what means so much to someone and what matters to them, we don't even think anything about it. And it's a really, really big deal to them. So this helps us focus on that and really try to dig those pieces out. Do you have anything else to add, or Pam, do you have anything else that you would like to jump in and add?
No, this has been amazing. I would like to encourage anyone to send in your questions to the chat so that these two ladies can answer them. I think it's really amazing that, and I'll be so interested as you will, I'm sure, to see in a year and 2 years what the Hope Tool what comes out of this and what changes for the good are going to hospice providers and others will see in the home care space. As we know, there's the demand for hospice is going to do nothing but increase while you are, continuing to face the workforce challenges. Will this tool be something that is multidisciplinary, in terms of really bringing your team together and being all on the same page, which is what it sounds like it is, beyond just being a great data collection outcome, operational efficient tool. Is that a right way to describe it? That you
I,
really are
I
able
think
to
so.
get everybody on the same direction in your hospice teams and be more efficient.
Yeah, definitely.
I think so. I think that's fair to say. And one of the things that is a big one of my hopes for hope, I don't know if that makes sense, but is that because we're collecting data at different time points that are more real time, right? Um, that even maybe that in itself will help the patient's voice, if they're able to express themselves, come through. And the reason I like that is that the survey that is applied at the end of hospice care is answered by the caregiver. Obviously, the patient has died, right? So I've always felt like the patient hasn't had a chance to give their feedback, right? So maybe as the Hope tool matures, we'll get more of a sense or more feedback from the actual patient that is being cared for.
Mm.
Not that the caregiver isn't just as important, caregiver and the patient are the unit of care, but the fact that the survey evaluating hospice services isn't even filled out by the patient, um, to me, it always feels like the patient is left out of the equation. So I'm hoping maybe somewhere in this evolution that the voice of the patient will be able to come through.
Yep.
Yeah, yeah, I also see, CMS initiatives across the board for years have been bringing families more into the fold of the care
Hmm.
team. That has been, in many other buckets that they are working in. So I see that with this as well, with the four M's. Um, I don't think anybody can disagree that the family is really part of the care team in a hospice with a hospice patient, and being able to include them and get their feedback as well is has got to be nothing but positive. And it's giving that direction and that, sometimes you just need a roadmap to get there. And this seems to be something that is going to help in that. Um, Tell me your thoughts on, family, the importance of families and how you've seen that change in, the last few years.
And thinking about it, I mean, we all know I get surveys for hotel stays and for different things. Do we
Hmm.
fill them out? Unfortunately, we don't always get the voice of anybody, or a patient may not have family at all. And so their voice wasn't heard at all. And so this is a really good opportunity to be able, I totally agree with Jennifer on that. I think that's a very valid point. And will hopefully drive it, bring out more information of what was the patient's experience like, not just what the perceived experience from the family, which is
Mhm.
again good because we also want them to have a great experience. But yeah,
Right.
really good.
I love what you said, Vicki. There are no do-overs in hospice.
Yeah.
I mean, you get one chance to make this an experience that's positive, as positive as it can be, and memorable and meaningful for the whole family, for the patient and the family. And that really is going to ultimately drive those to refer others. I mean, it's let's be honest, people do talk to each other, and that's how they're
Sure.
going to find out, this hospice company really made this difficult time for me the best it could the best it could be, right? And that's ultimately what the goal is.
Absolutely. I do see a question in the chat, and it's actually a great question. It says, do you think the Hope Tool will help physicians better understand and embrace the value of hospice care for their patients? I hope so. That's my answer. You know, because it is a tool that really is just within the hospice arena right now, other physicians might not even know about it. So, if you're a physician or if you work outside of hospice, definitely share this information because it could be a mindset changer. I mean, I know that I've met plenty of physicians that are amazing and they will say, I don't really know anything about hospice. They're almost uncomfortable. They will refer a patient and they do the warm handoff because they're like, I don't know how to manage my patient's pain and symptoms at that level of care. And so, they just didn't get the training or education. But it could potentially, if we can get the word out there, and kind of get that mindset going in that direction for other areas, I mean, it would be great. It would benefit
Yeah.
patients all the way around.
I agree 100%. And, opportunity for those hospice community educators and those who are, working in the communities and to, give them the opportunity to go into some of these offices, have these conversations like we're having here on what is this? It takes a while for things to take hold.
Yeah,
And October was not that long ago. So,
yeah.
I certainly didn't know about this in October. So, um, uh, yeah, this has been very, very informational for me, and I'm sure those on the call with us. This great CHAP team is helping us create an ebook on our Compassionate Touch program, which we have put into the chat for you to be able to download the white paper if you want. But we will be working on that ebook together. I can't think of a better group to help me with this. You are just experts at so many levels and so appreciated. But I think that will be a different viewpoint, if you will, on looking at the Hope 202 in terms of symptom management and using holistic tools like compassionate touch. And you mentioned music. There's so many and I think this too is a CMS initiative is what else is out there besides a pill? We have to be looking at all those things now that are becoming more not just readily available, but people are really embracing the more holistic tools, right? With all this, that's just the direction. So yes, we will be sending that out. I do so appreciate your time. I'm looking to see if there's any other questions, and it doesn't look like it. Certainly, anybody who wants to reach out to either of us, you have our emails, and we encourage you to do that. If you send us a question related to the Hope Tool, we will probably send it right on to the CHAP team. But thank you, ladies. This has been really inspirational as well as informative on this tool. And it could not be more appropriately called or named than Hope Tool, right? And I hope,
Agreed.
yeah, I hope that in a year and two, 2 years, 15 months, 2 years, that we're coming back and saying, wow, this was great. And look at all the outcomes that we've seen. And that's our hope. So thank you. And thank you everyone for joining and certainly we want you to continue to stay connected with AGE-u-cate and our programs. And so I will say we can end it a few minutes early with no other questions. And again, my sincere appreciation to you both.
Have a great day.
All
Thank
Thanks
you.
right.
for having
Bye-bye,
us.
everybody. All right.
Bye-bye.
Bye-bye.